All right, so everybody's favorite abnormality on a chemistry panel is hypercalcemia because it has such an easy to remember mnemonic. So before we get to hypercalcemia, I'm going to be a broken record and remind you again that how PTH, vitamin D, and calcitonin work, because if you remember these three things, it makes everything easier. So PTH, vitamin D, calcitonin. Of course, PTH increases calcium and it decreases phosphorus. Vitamin D increases both, and calcitonin tones them both down. Also, PTH is also going to increase magnesium, just as a remembrance. Okay, so you've got two options here. You actually have three options. So you can use everyone's favorite mnemonic, hard-ons G, to remember it. Some people like hard ions G. Or you can use the more appropriate gosh darn it, you name it. I'm going to go with what I have in the notes, which is gosh darn, but again, you can rearrange it any way you want. So G stands for Granulomatous Disease, and this means that there are macrophages, specifically epithelioid macrophages, from granulomatous inflammation, and it makes a vitamin D-like substance. And so if you remember how vitamin D works, it's going to increase both calcium and phosphorus, but it tends to be, I want to say, really mild increases, so maybe only a point or so increase. And of course, it's going to increase both mildly, and we're talking ionized calcium as well will be increased. What causes granulomatous inflammation? Well, commonly fungal infections, which we don't see as much up here as where I was before. Some higher order bacterial infections, and this is primarily a dog thing. So what kind of support are you going to look for? You're going to look for things like inflammation on the leukogram. You're going to look for an appropriate geography of where we see fungal infection. Maybe you see enlarged lymph nodes or potentially pulmonary disease, since a lot of fungi go to the lungs. Okay, so that's granulomatous disease. O is osteolytic disease, and I find this a little hard to understand sometimes because it overlaps with other diseases. So osteolytic disease, meaning the bones have lytic lesions. So this could be something like osteosarcoma. It could be something called like multiple myeloma, which works in another way. That's lytic lesions in the bone from plasma cells. So you might look for a lame dog. You might look for a dog with a really, really, really high globulin. Of course, a blast from the past. What do we see? We see a monoclonal gammopathy. If we do special tests, that's supposed to be monoclonal. And that's on your serum protein electrophoresis. Osteosarcoma, you're going to look for fractures. That is not present on blood work, obviously. That's, I think, less common, so we'll put some parentheses there. All right, you may also see something increased called alk-phos. All right, so S, which used to stand for spurious, which is so spurious, or we'll make it an I. We now recognize idiopathic hypercalcemia in cats. This is kind of a diagnosis of exclusion. And idiopathic hypercalcemia, again, it's a cat thing. You have to rule out other causes. All right. One of my favorites, hyperparathyroidism. So we're going to just call it hyper-PTH. And this is a neoplasm, either a parathyroid adenoma or carcinoma of the parathyroid gland. And this is mostly in dogs. And so they have a neoplasia that makes PTH. And so what happens is you get an increase in calcium, but PTH decreases phosphorus. So what kind of signs do you see? Well, most of the time, 65% of the time, you're going to see concurrent hypophosphatemia. But remember, you may see a decrease in urine-specific gravity because that hypercalcemia causes nephrogenic diabetes insipidus, right? It affects ADH. Of course, how you diagnose this isn't just from a serum high calcium and phosphorus. You're going to diagnose it by measuring ionized calcium At the same time, you're actually measuring PTH. And if ionized calcium is high, what normally happens is that should suppress PTH, right? So that would be normal, is that PTH would be low. But what would be diagnostic for hyperparathyroidism is that you have a high ionized calcium and it's due to an increase or even a normal PTH, because that would be an abnormal finding. So it's this increase in PTH from the tumor that is causing the ionized calcium increase. So that is how you would diagnose that. And that is primary hyperparathyroidism. There are secondary types of hyperparathyroidism, which is different. This is primary, meaning an increase in PTH. All right, another favorite, although it's a terrible disease, is vitamin D intoxication. And this is a very, very bad intoxication. There are rodenticides that contain warfarin that cause clotting abnormalities. And then there are rodenticides that contain cholecalciferol. So that's a rodenticide. You'll learn about that in tox, I hope. Cholecalciferol, and even some plants that contain ergocalciferol. And of course, since this is vitamin D, we're going to see increases in calcium and increases in phosphorus. And if it's cholecalciferol ingestion, we're talking marked increases. So like, normal calcium maybe is 9. We're talking anywhere 15, 16, 17, 18. So these animals have marked increases in calcium phosphorus, which of course that product is much greater than 70. That did not write. So it's much greater than 70. So you see rampant tissue mineralization that causes animals to go into pulmonary distress because their lungs mineralize. These animals go into acute renal failure because their kidneys mineralize. And opposed to ethylene glycol, which decreases calcium, of course, this increases calcium. They also mineralize their GI tract, so you can see really severe GI disease and bleeding. And these patients often will die because of this just widespread mineralization. I know this is terrible what I'm about to tell you, but some people inappropriately call them crispy critters because these animals literally just mineralize. I know that was terrible, and I feel bad for even saying it, but sometimes people remember things, but our crispy critters, vitamin D intoxication. There, I said it again. All right, anyway, A is Addison's disease. And so this is a weird one. So everybody loves Addison's disease. Well, all clinical pathologists do. And of course, that's due to, right, so you have decreased cortisol and you have decreased aldosterone. And we've talked a lot about the aldosterone part. That makes you dehydrated. You get a decrease in sodium and chloride and an increase in potassium and all those things. The cortisol is you lack a stress leukogram. That is messy handwriting. You have a low glucose, and you have sometimes a high calcium. And this is because cortisol allows you to excrete calcium. So without cortisol, you don't excrete as much calcium. This is not true of all Addison's cases, but it's true of some. All right, renal disease. Most of the time, renal failure causes hypocalcemia, but in around 10 to 15% of small animals, they will actually get a decrease in they will get an increase in calcium. So that's uncommon. And so they'll have an increase in calcium and increase in phosphorus. Now, it's more common in horses because horses, especially in acute renal failure, where they're maybe not making as much urine, and since they excrete so much calcium in their urine via calcium carbonate crystals, you will see actually an increase in calcium in horses, again, with a decreased urine production type of acute kidney injury. Horses are kind of funny with their renal failure, I will say that. What you do see in chronic renal failure is you see most often in small animals a low calcium. And this actually results in an increase in PTH. And so that increase in PTH is a secondary increase, so it's called secondary hyperparathyroidism, but the driver is a low calcium, so that is not on this page. All right, so the last of the hypercalcemia causes is another favorite, which is neoplasia. And this can be due to something like Lytic disease that we saw with multiple myeloma, or it can be due to something called PTHRP. And PTHRP stands for parathyroid hormone related protein or related peptide. Excuse me, not hormone, related peptide. And so it's going to work how parathyroid does. It's going to increase calcium and it will often decrease phosphorus. And the neoplasias we see lymphoma, we can see multiple myeloma, and we can see anal sac adenocarcinoma and a few other oddballs. There's actually many of them that can do it. But the ones that make PTHRP are often the lymphomas and anal sac, possibly also multiple myeloma. So how do you diagnose that? Well, if you have hypercalcemia and you diagnose one of those neoplasms, it's usually going to be enough. But you can actually measure PTHRP, and it should normally be undetectable, but it can be increased, and these are special tests. So lymphoma, you're going to look for other evidence of lymphoma. Multiple myeloma, I explained earlier. And anal sac adenocarcinoma is usually an anal sac mass, and you do cytology to identify it.